Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this episode was recorded at SOMSA 24 in Raleigh, North Carolina, with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
Again, this is who I want to hear from within Special Operations Medicine, those who have experience on the ground and teaching great medicine. And they're going to tell us today about why your medics suck and what you can do about it. Please welcome to the stage a great group of gentlemen.
All right, good afternoon. Nikes, look at all these people here. The title, Why Your Medics Suck and What You Can Do About It. How many people came here because of that title? Yes, success, it's total clickbait. Not all of your medics suck, just some of them. So, like you said, I'm Rick Hines. I'm the primary instructor for our Skills Sustainment course at the JSOMSA, the Joint Special Operations Medical Training Center. So we have medics come through every 2 years to recertify and reblue their skills. So what we want to talk about here is some of the trends that we're seeing as they come through the course. We've collected some data, pass-fail ratios, and all of this stuff. Now, none of us are statisticians. So when it comes to analyzing the data, that's not what we do. We've got day jobs. We should probably stick to that. I would love to have somebody come out that is their day job and they're smart on that and to help us analyze and see what it means. What we're going to talk about is just the data, some pass-fail rates, and some best practices that we're seeing and some issues that come up when the medics come through our course. So the medics that come through our courses are, of course, the AT Deltas, the Ranger medics, the Task Force 160, the Civil Affairs, PSYOPs. We have 528. That's for the Army side, the USOC medics. We also have MARSOC corpsmen come through. And we have some NSW. We're probably going to have more soon, is the rumor. So anyway, that's the population that comes through our courses that we're going to be talking about. So if that's not one of your medics, I'm sorry, send them to our course and then we'll talk about them next time. So I'm going to, can we have the next slide, please? Oh, nice and simple. Big green button. I like it. Oh, okay. So our agenda, the mandatory agenda slide, you can see the different topics we're going to talk about. And I'm going to let Sergeant First Class Dan Adams go ahead and start us off here with some of the data here.
Good afternoon, everyone. Thank you for coming. Appreciate the attendance. We did this last year. We had the last presentation on the very last day, and not very many folks were here. I think the message is important for the community as a whole, so we appreciate the support getting bumped up to a prime time spot. We're happy to share things with you. Just give my quick little intro. I'll talk about the specific things here, but the whole point of this is an introduction, a public introduction from myself, from Ben Harris, to you guys, because we are in a very unique position to see all of your medics come through on a regular basis as they're mandatory training every 2 years. Right, so we have eyes on the population as a whole, not just for a specific unit like you guys do. So if there's anything we can ever do to help drive your training, to help give you some feedback, some guidance, so your training can be a little bit more specific and pinpoint to maybe your unit needs or just the medic population needs as a whole, please let us know. We're collecting that data as best we can, even though we're not very good at it, I'll admit. We're doing what we can to give you the information to hopefully make your training that much more beneficial to the medics that you serve. Okay, so I'm going to talk about the two sustainment courses that we have at JSOMSA. If you're not aware, there are two separate courses. They're both separate ACART, actual separate allocated courses. This happened about 2 years ago. They split and became 2 separate courses. So you have the Special Operations Combat Medic Skill Sustainment course. That's SOCMA-C. That is colloquially referred to as the refresher course, as it's been referred for a while. Right? That's the common one that everyone comes to renew their Advanced Tactical Paramedic license. That's the SOCOM requirement for the soft ground medics, at your ATP license. The Special Forces Medical Sergeant Skills Sustainment course is a 4-year requirement, so 18 Deltas SOIDCs, those long course graduates have to attend this course every other time they go to recertify their ATP. They're supposed to go to this course. Right? It also renews the ATP, but it does a lot more on covering the specific long course skills, such as the things leading up to PFC and surgical work. Both courses renew your ATP license, ACLS, BLS, PEP, and REMT basic and paramedic is renewed in both of those courses as well. So SOCMA-C, this is a 9-day course with really 7 training days if you don't count day 1 in processing and the day 2 are outro. Day 1, we in process, we do some lectures. You're split into your 6-person small groups, which is where the meat and potatoes of our courses run with that collection of 6 students and 1 instructor. Day 2 is a long tabletop surgical skills day. We also cover pathophysiology and some common things, hypovolemic shock, we do blood transfusion, tension, pneumo, we induce crush, we do ACLS protocols, all of that on a tabletop patient role model day. Day 3 through 9 is really where we get into what we do at our course and what makes our course so special and beneficial for medics. We run high quality trauma scenarios for the medics, and they are being evaluated. In the past 4 years, the course has moved to it's an evaluation for these medics. Like their skills are on the line, and if they don't pass the course, they don't pass their scenarios, they do not renew their license. Right? No longer is the sustainment course, a refresher course, a place to come and hang out for 2 weeks with your buddies and you leave with your medical license renewed regardless of your ability to do so. Right? It should be no secret at this point, everyone's been through that's currently active medics, like they know the deal. You've got to be prepared to come to the course because your skills are going to be put to the test. And we're going to talk a little bit more about precisely how we do that. So yeah, we do 2 hours of lecture in the morning for the majority of that course. We cover all things, blood transfusions, TBI, burns, a good bit of pharmacology work. That's a point with the medics that they need a lot of work, it seems. About 10 o'clock, we split your small groups, and then for the rest of the day, you're with your small groups running your medical scenarios for however long that takes. So for the SFMS course, it's a 14-day course. Day 1, and really the first week mirrors SOCMA-C. They're getting through all their graded medical evaluations to renew their ATP. They'll know whether or not they pass that course after that first week, and then they'll move into their long course specific training. Day 6 through 7 is CPG reviews, lab skills, going over nursing care, ventilator management, ultrasound, employing some of those high fidelity pieces of equipment that most medics don't touch as often. It's not trained on as much. Days 8 through 14, they're doing point of injury care into austere damage control resuscitation, and then all the way to definitive surgical treatments in the ORs at JSOM-QC. Right, it's a great course. First week renews your ATP just like SOCMA-C, and then they're learning a lot of skills in a non-graded environment to keep all those. It's pretty hard to keep up with skills. Great course. Jim Harris is the NCOIC for that course, and I'm the NCOIC for SOCMA-C. All right, so we're going to talk a little bit about how we run our graded medical scenarios. This is really what we take a lot of pride in, and what I think we owe the medics a lot of effort. Like, we need to get this right. We're evaluating them, but we are their peers. We're medics just like them, but we've been put in a position to run quality training, evaluate them in order for them to renew their licenses. So it's something we take extremely seriously. We put a lot of work into getting it right. Each student will get 2 chances to demonstrate their proficiency while they're a student here. All right, those scenarios can include a myriad of things. GSW shrapnel, your typical bullets and shrapnel, thoracic injuries, MSK, anaphylaxis, burns, TBI, hypovolemia, heat injury. There's all sorts of things that we could throw at them. Some of them being more complicated than others, but the actual critical criteria for passing these lanes is very achievable regardless of the scenario that the medic may be faced with. For example, let's say we have a blast injury. We've got shrapnel, we've got legs amputated, we've got a ton of bleeding. Critical criteria to pass that lane is achieve HMCON, be a tourniquets or whatever works for that scenario. Provide damage control resuscitation. For us, that's 8 units of blood, because blood is what saves them. Conduct your evacuation, don't delay that evac for anything. And then cause no further harm is our big catch-all, right? And that's the one, honestly, that gets patients or medics the most, is that cause no further harm piece. We constitute further harm as air in the bloodline or sending significant amount of air to your patients when you're resuscitating them via blood transfusions, which happens quite often. And medics don't train on it much. They get here and they're stressed. Like that happens very often. And then wildly inappropriate narcotic usage that would cause further harm to the patient just from a lack of familiarity with that. And there's some other silly things that happen. You guys fail to strap people on a litter and actually dump it upside down on the concrete. Little things like that. All right, for the most part, we don't have a very robust grade sheet for a very specific reason. We don't want to get pigeonholed into like 15 things they have to do in order to pass. We want to see them think critically, make the right decisions for that patient, and do the big things that are going to save that patient and create a better outcome for them. Okay, so first run is typically a relatively uncomplicated scenario. But again, some are more complex than others. Critical criteria is adjusted for that. If the medic passes that scenario, potentially that next scenario that their instructor comes up with for them is more complicated or has multiple patients or is more specific to their job or their future deployment or something like that. Like something more challenging to give them the opportunity to grow. Should they not have passed their first scenario, they're going to get a second scenario, which is going to be relatively uncomplicated as well. We're not going to throw a mass cow at someone that didn't pass this first lane. Right? We're giving them every opportunity to demonstrate baseline proficiency here. Should they pass that run, they pass the course, no problems. And we'll get into the numbers on the actual specific pass rates here shortly. If they do not pass that second run, right, they'll be given a third medical scenario. This will be their final chance to demonstrate proficiency before they leave the course. That'll be proctored by the exact same instructor that's been running their training for the whole week, the whole 2 weeks. We're not going to throw a new instructor that's got maybe a slightly different way that he presents patients. It'll be proctored by the same instructor, but it'll be observed by no less than 3 other committee members. Typically, there's 5 or 6 of us watching that scenario. We do it for a couple reasons. We want to ensure that our instructor runs a near flawless scenario and that there's no chance that anything was confusing or not done well. So that might have influenced the medic's abilities to make proper decisions and do proper treatments. Right? If ever there is a case there, the benefit of doubt always goes to the medic. Right? It always goes to the medic in that case. We're also there to provide objective feedback on that medic's performance. All right, if the medic passes, they renew their ATP card just like anyone else in the course. Should they not fail, they will not renew an ATP card. They do not lose their card, nothing disappears, they just do not get a fresh expiration date stamped onto their ATP license. All right, they are free to come back to our course 6 months down the road. 6 months at your unit to retrain, to get your skills back, come back to our course, and knock it out and get your ATP. Okay, this slide is denoting pass rates by unit, and it might be a little hard for you guys to see with that white font. Pass rates for fiscal year 2024. And this is what most people are very interested in hearing from. Of the 214 Special Forces group medics that came through last year, we had a 63% run 1 pass rate and a 92.8% pass rate for their second evaluation. In total, you can see the numbers down there from 1st, 3rd, 5th, 7th, 10th, and 19th group. The 0 out of 1 denotes that they were 0 for 1 in passing that third scenario. So 1 from first group this past year did not pass the course. Give you guys a minute, you can look at the numbers. I'm happy to email any of this out to you guys if you want the numbers specifically. And again, these are the pass rates you're looking at here. So across the board, we're looking at about an average of 65 to 75% pass rate for their first trauma scenarios there. We kind of view this as it's more closely related to them encountering a patient in the wild, right? They haven't had a chance to knock the rust off, to be there for a week watching and practicing medicine to then get an attempt. Like their first go potentially on day 3 of the course before seeing anybody else do a medical scenario. Run 2, we're looking at close to 97% pass rate for everyone on that second evaluation. And then in total for this course, we're sub 1% people that do not pass the entirety of our course. So in total, you can see fiscal year 21, which is when the course became a pass-fail course. Fiscal year 22, 23, and 24 as far as the failure rates. These are the amount of people that did not renew their ATPs coming out of the course for the last 4 years. Okay, some observations. I'll get into a little bit of that, and Ben Harris is going to pick up with a lot of the trends we're seeing with the medics. In some ways, maybe we can focus training a little bit better. The big thing, overarching theme, is units that conduct regular medical training perform so much better there. The ones that don't perform medical training, their units often are the ones that are struggling. Right? And that should be a no-brainer to us, but like the numbers speak for themselves when we really get into them. Those that conduct training, they have far better understanding of A&D, better understanding of the effects that wounds can create. They're hands-on during our skills stuff, but it's so much better than the person that's doing it right again for the first time in 2 years. Noticeably, they're less stressed. That's the big thing. Like they're more comfortable in that environment where they're treating a patient. They've got to do skills that require fine motor movement. They're just calmer, less stressed, doing a lot better treatments and doing them more efficiently. Communicate well. Motor skills tend to stay intact for those that are training regularly, and they're able to actually think up and out and not just get hyper-focused on the patient that they're treating. The current knowledge of TMEVs, Ranger Medic Handbook, whatever protocols they fall under, teach recipe guidelines is far better in a unit that actually puts emphasis on that. And then their feedback during the ARs is much better. And that's a huge thing where a lot of that learning takes place, is those conversations that happen for an hour to an hour and a half following the scenario where we talk for quite a while sometimes, really breaking down what that medic did and how they can improve. Right, so they're better at training their fellow medics, what it boils down to when they're trained. I'll turn it over to Ben Harris. He's going to talk through some of the protocols and the issues we see medics struggling with, and a few equipment shortfalls, and then I'll wrap us up at the end. We'll take some questions at the end, but we are more than happy to hang out in the back there for as long as you guys want to hang out this evening and have conversations about this topic.
Hey there. So, like Rick was saying, we don't do data analysis, and like Dan was saying, we do have some observations. So what we did want to try to do is offer some solutions if possible. Keep in mind that Dan's predecessor, Eric, started doing this collection just a couple of years ago, so we don't have 20 years of history recorded for this. Some of this is anecdotal and talking to the small groups. Some of this is recorded from direct surveys across the force for anybody that would reply. I think the slide is pretty straightforward. These are pretty common things. So when we talk about, TBI and lack of familiarity with the protocols, a lot of what we hear is, I'm just kind of bagging down. Like everybody is just going to be okay with you hooking up the tube and forcing air into their chest against their will. It's just a lack of experience in dealing with it. And it's not any individual's fault. It's just lack of familiarity. Anaphylaxis. I will say that in all of our medics' defense, they changed the labels on the epi bottles not too long ago. And we're still talking about what's 1 to 1,000 versus 1 to 10,000 and what's a 1 milligram. So that's not exactly fair. So decompression of the thorax is pretty straightforward. Where are the sites? Where are the landmarks? Where are they going? When do they need to do it? Understanding the patient's physiological response to the trauma. Management of shock. A lot of the time, it's slow to pull the trigger on damage control resuscitation. Is this patient in shock because he still has a radial pulse? What's the indicator? What's the trigger point? Skills. Every soccer medic can do an IV with one hand behind his back in the dark under nods, right? Or maybe not. Maybe it's a little bit harder to do when your heart rate's up and you're sweating and you're in the dirt and maybe you're in a confined space or in a moving vehicle. And when we don't practice skills like this, then they become even more difficult. So if I don't do this for 2 years and then I come back to the course, I might struggle to get an IV in a well-ventilated room with lights and a table and support. So imagine what it's like for somebody in a shocky patient. Vessels are going flat, trying to get a large bore IV so that I can do DCR. Regular practice is something that we have to keep up whenever possible. Junctionals would be tough for anybody. So, there's not a perfect junctional solution for every patient. And we put a lot of words under here. But what we do recommend is go back to the basics with direct pressure, wound packing, using a Doppler or ultrasound to verify that you have loss of fetal pulse when you're attempting to occlude those arteries in a junctional. Carrying on, pretty straightforward skills. Placement, guys. So where does the needle D go? Where does the chest tube go? Anatomical landmarks are something that we should be very familiar with before we try to do one of these procedures. We could do further harm, obviously, right? We're talking about surgical intervention done in a hospital in a sterile environment, and we expect our guys to do this in a dirt hut or on the side of a building, low visibility, denied territory, right? Ventilation management, kind of already talked about that a little bit, and the training scars are something that I kind of skipped over a little bit ago. We do often hear things like, I'm just gonna get an IO. I am just gonna crike him. I am just gonna do a chest tube. I'm just gonna bag him down. My patient's breathing fast. He's hyperventilating. His end tidal is too low, or his SpO2 is inadequate. And these are training scars that I think that come from us kind of finger drilling training elsewhere. So many of our teams come to us and tell us that at home, whenever they do cephalic or other urban combat courses, that they take a casualty every time. Every scenario has a casualty. I ask them, so, what's that casualty look like? GSW to the chest. Okay. And then what? Well, we put them on a litter and we evac them. You get the feedback when you do interventions. Well, no, because I'm the medic. So who's giving the medic feedback while they're doing their training? Who's helping them to simulate a physiological response from the casualty on the X? And it's usually nobody, because that medic that is now coming back to renew his certifications has been the one giving the feedback to everybody else doing the cross training. We kind of already talked about DCR. We had a period of time where we didn't do blood training at the JSOMTC. And during that period of time, we saw exactly how bad it was that we couldn't do it. You can get filtered Y tubing, you can get, crystalloid fluids, and you can write low titer of whole blood on it and expect them to use it in place of blood when indicated. But there are so many things that come up with the viscosity, the color, the consistency of running real blood into a patient that you don't get from a clear crystalloid fluid. And that's just something that we need to do here all the time. Some of our best medics have difficulty with the Y tubing. Unfortunately, it's you fill up that chamber and you don't know if it's flowing. It runs 15 minutes goes by and you realize that you have no flow, and now you've got clots in the line south of the filter. These are things that we have to do all the time, especially if we're going to do it on somebody else's worst day of their life. And this is my life-saving intervention, and I only carry 2 units of blood. And then, like I said, a lot of what we do is anecdotal questioning. So we're in class right now for the SFMS Sustainment course. And just to make sure that I wasn't way off base, I periodically like to go into the OR or go into the training room and ask them what they're doing and how things are going, and make sure that I'm not getting way off base, because we said a lot of this stuff a year ago. So we asked them if they have access to the equipment that we use in our course, and do they have access to the drugs that we use in our course, things like injectable fentanyl, propofol. Do they have access to a ventilator, or they still have the Save One in their team room? And a lot of them tell me that they don't have regular access to it. They don't have the ability to draw propofol or injectable fentanyl. And that is stuff that's trained in SFMS. Those 18 deltas do receive initial training before they go to the groups, but their unit surgeon or whatever medical chain of command is not okay with them drawing that prior to deployment. And then just when you don't have it, you don't get to use it, and you don't get to go do your hospital rotation but every 2 or 4 years, and that's your only time interaction with a real live patient, besides when they come to our course. Then you do have unrealistic ideas of what the onset and duration of action are. I give you an IM injection in your right deltoid and expect to have some kind of reaction 30 seconds later. It just doesn't work that way, and I think you all know that. I'm not going to beat epi to death. It's not fair. Go back to 1 to 10,000 or keep it 1 milligram per, whatever. Just keep it the same way forever. But understanding when, how, and why to use that. Guys are scared of that. It's considered a cardiac drug. It's just not something that they push a whole lot. We need more interaction with real patients outside of every 4 years coming to our course. Ketamine. ketamine is ketamine, right? We're probably not killing people with ketamine, but what are we trying to achieve when we push the drugs for all of these? It's not just for ketamine, but whenever we go to push 50 micrograms of fentanyl or 20 milligrams of propofol or 500 of ketamine, why are we doing it? Is it because we heard that dose somewhere and we're repeating it? Because now I'm stressed and now I'm in a situation where I'm unsure what to do, but I remember that number associated with that drug? Or do I have an actual goal? Am I trying to achieve deep sedation or pain control? Or am I just trying to help him get through the moment so that we can do something else and get him off the X? These are things that just come with regular use and repetition that we just don't get a whole lot of. The equipment, I know somebody in this room is going to tell me that I'm wrong here, but most of our medics do not have this equipment in the team room. It's been fielded to a lot of the groups, a lot of the units, but if they want it, they have to go find the owner, which is usually at the group or battalion level. They have to sign it out. There's not enough to go around. If we expect these guys to be able to maintain a multi-system trauma patient in an austere environment without an actual doctor or a team of medical professionals to help them, it's just one 18 Delta and a few of his cross-trained 18 series MOSs or a SOCM Ranger medic that maybe doesn't have evac coming, then they're going to need more than what they carry in their AVAC. If this gets back to the team house or it gets back to their fob and air is red, they need to know how to perform a fast exam. They need to know how to confirm that there's lung slide with the ultrasound. If they're going to do a regional block, would really like to be able to take a visual of the nerve bundle prior to doing that. Guys are scared to death of ventilators, and they should be, because we often don't know a safe procedure for setting it up, even after our classes. And it's not any individual's fault, but if you don't touch this thing but every 4 years, then when we tell you that it's time to use it in training, then maybe you do just plug it up to the patient and turn it on and hope for the best. And that's not the right answer, guys. Stimuplex needles, if we're going to do regional blocks and we're going to try to conserve our drugs and use a multimodal approach to anesthesia, then we definitely need to have access to the equipment and the disposable items that are necessary for that. You guys still have a lot of trouble getting a hold of Stimuplex needles, which are on the approved stockage list for every group. EMAs, I'm now hearing from most of our medics that come through the course that they have access to an EMA on a regular basis. So if that's a change over the last year, you can understand that there's a lack of understanding across the force of exactly how it works, what to expect, turn on, shut off procedure, and what the normal range is for a healthy human being. The TCCC CASEVAC kit and the transport modules are great additions to our repertoire and absolutely essential, but we need to have access to them. If you've ever opened that kit up and taken a look at them, then you know that it's not all the same manufacturer. They don't have the same cords. The power cords don't interchange from one device to the other, so you need to have a basic understanding of how to turn all the equipment on first. And if you don't touch it, you don't see it until it's time to go, until you've requested it from your battalion or from your group, and you're getting ready to deploy on a JSET or potentially a combat mission. That's not the time that you want to get familiar with how to turn on the monitor. And then, like we were talking about, the need to transfuse real whole blood. In order to do that without purchasing a million of these pre-made kits that are super expensive, the Vampire kit from several commercial off-the-shelf manufacturers, you need to be able to get a case of just the blood bags. And a lot of our guys are having trouble getting that on the approved stockage list. You want to do large amounts of training, you want to do repetitions, you want to be able to do this every few months, then you need to be able to get that without, blowing your entire medical training budget on the transfusion kits. So recommendations real quick, and I'll pass back off to Dan to close this out. We strongly believe that we need to have more medical training at the unit level. Like I said, a lot of the time they have, we take a casualty on every training mission that we do, and the depth of that casualty is only he's bleeding. Okay, put a tourniquet on him, stopped it. There needs to be somebody to give the 18 Delta or the SOCM their feedback on what they do, so that when you're treating your patient on the X, you know if what you did was effective. It's more of a mental drill than anything else. But we need to do, we need to think it through, and we need to touch it. We need to feel it. We need to move it ourselves, and we need to see what happens when I do X, Y, or Z. We need to get feedback on that. I'll let Dan close it out real quick.
So one of the big things that we see when we talk to medics that particularly are struggling, or it's clear they haven't done this in a while, is that they may have done medical training, but it wasn't proctored in a manner that really benefited them, or that showcased that they had some deficiencies they need to work on. Like, we get pretty close to run pretty decent medical scenarios, but if we don't push it to a certain level, it never gives the medic the opportunity to fail, to be honest, right? They're not held accountable. The patient feedback is not run in an appropriate manner, if even run at all. Quite often it's not, because casualties are given to someone that doesn't take cover on a full mission profile in a unit, and then that guy's told he's got a shot in the leg and just carry him on a litter, and that's the extent of the casualty thing that we did, right? There's not a place for that. It's not beneficial for the whole team to learn to evac a patient, call all that up. But a lot of our medical training is missing the mark, and medics aren't getting stressed to the point where they're really actually putting their skills to the test and learning what they need to improve on. So just a few recommendations on that. The patient feedback needs to be really on point in order for that medic to get the realistic feedback and to know if what he's doing makes sense, if he's doing the right things. Right, the timeline for the onset of shock, right, is quite often just pretty cut and dry. This patient's in shock or he's not. Or you get there immediately right after their shot and they've already lost radial pulses from a leg wound. And then we don't have any realistic trending or way to differentiate the stages of shock that medics need to be good at in real life. Following interventions, like the feedback needs to be realistic as to how long it would take for this to work, or for this drug to onset, or for this to work. Right, that's something medics say. Usually I do it and it's immediately fixed. And I don't know what a realistic timeline is for ketamine or this drug to actually set in, because they give it and 2 minutes later all problems are solved as far as the medication goes. Drug administration accountability is huge. That's probably one of the things that medics struggle with the most. Reading the drug concentrations, drawing the correct amount, giving it the correct route, and then knowing the physiology and how that's going to work and the timelines associated with that is a big problem that we see pretty much across the force, outside of those units that actually get the chance to push this stuff in real life, or doing medical scenarios where it's realistic feedback given to them. We quite often see issues with it. The workaround, or the way that we kind of draw that out of the medics if they're unsure about their medications, and we force them to use 10 ml saline vials that we put a sticker drug label on there, and we know what their concentrations are. The instructor knows precisely what they're carrying, what the concentrations of the drugs they're carrying for their medical scenario. So we know that they picked up their ketamine, and from across the room we can see that they drew 1.5 cc's. We can see that they slammed an IV and they didn't flush behind it, and you can give them appropriate feedback to that, because we've done our work on it ahead of time to know precisely what they're carrying and how they're giving it. All right, and we can give appropriate feedback based on what they do. Administering at appropriate speed is a big thing too. Most medics just push drug real fast, IV, and then flush behind it or forget often. And we give appropriate feedback based on what that would do for the patient if that drug was slammed in, for instance. We focus on critical thinking over any type of algorithmic-based medicine. Like, we're giving them the tools to assess a patient and do appropriate treatments based on their assessments, not necessarily just do these 10 things in order and we're going to present the patient the same way regardless of what you do. So what we give them for feedback, how that patient presents it, is completely based on what they're doing, what they're evaluating. Right? I think that's pretty crucial running a quality scenario that gives them the opportunity to grow or showcase their shortcomings. Last slide I'll leave you guys with is kind of the recommendation from us and the recommendation from a lot of medics that have come through. So when we brainstorm with them at the end of the course, like what could be done to make training better for you guys at your unit level? And it's not necessarily we need to do more of it. It needs to be done to a slightly higher degree. Folks need to be trained on how to run patient feedback for us is the big thing that we hear from them. And we do agree with them. I think as far as coming from the SF group, where I'm coming from, Advanced Skills Company, holds the sniper detachments and things like that. If there were a few people there whose job it was to run quality medical training on behalf of the teams or the companies that are running their full mission profile, their big events. They could just insert into different units training and make the patient casualty feedback piece quality. I think that would go a long way to cleaning up a lot of the issues here, right? They could potentially be prepared to come to host and run some micro small scenarios for medics that have a day or two to go and kind of get the dust knocked off, but really the ability for them to flex and seamlessly integrate into the unit's training to make it really beneficial to the medic, I think would really pay dividends. I don't know what that looks like. I don't know what it looks like at other units or how that would work, but I think having a couple people specifically trained to run that piece that can bounce around would be great. If you have any questions, feel free to ask them here. Feel free to email myself or Ben Harris. You can scan the QR code, that'll get you an email to our joint email for the courses here. We are running a lab. I believe they're probably both sold out at this point, but for Wednesday afternoon and Thursday afternoon, we are running a lab. You're going to see a SOCMC style small group for a day for that 5-hour lab that we're doing. We're going to start to finish with the mission brief and the medic. We're going to mobilize the patients. We're going to do treatments. You'll probably see us running around carrying a litter with real patients on them, or simulated patients, I'll say. And you're going to see start to finish how we run a medical scenario, and then we'll answer any questions that we possibly can for you guys about how to improve the actual medical training you're running at your units. If you can't make that, you guys are always welcome to come out to our course, either course here. In fact, any provider, PA, or doc that's at the battalion level that has ATP medics under them is supposed to come to our course and audit it. It's written in 350-1. You have 6 months to do so. By all means, please do it. All right, you will see this stuff play out firsthand, and it might really drive the way you run training at your unit. For anybody else that wants to come, just shoot me an email. We'll work with a schedule. We'll get you in for a week, ideally for a whole 2-week class. You can come audit, see what the ground truth is about how your soft medics perform. It's surprising. I think we have a very false sense that soft medics are good, and all of them are good because they all went to SOC med. They're all the exact same amount of good, for lack of a better term. It's not the truth. It varies wildly. The ones that trained are pretty decent. The ones that don't train are pretty rough to watch, and it can also be pretty scary. So please come see it. If there's any way we can answer any questions for you guys, we'll send you the slideshow, any information we have to help improve medical training across the units. We're here for you guys. We'd love to have you come visit us and hang out. Thanks for hanging with us. Appreciate you listening to us. By all means, if you have questions, we're here to answer them.
Testing. Long-time listener. Jeremy. So this has been asked to me quite a few times over the last, 10 years. So for MPT requirements, do you see SOMA ever able to come up with a construct to meet the non-trauma module standards and that need to be met during the SOMA conference for those individuals that need it?
So there are some organizations that give non-trauma credit for SOMA, for attendance to SOMA. The way the reg is written, it is pretty much to the brigade level surgeon as to what the non-trauma looks like for his unit. There's leeway there because of different AORs. Now that's really not our realm. That falls under USASOC. The 350-1 kind of covers that requirement, and they would be the ones that would determine what actually meets the requirement for credit or not. MPT is different. It's laid out in the same reg, and then 350-29 for SOCOM kind of covers that for SOCOM, but specifically for non-trauma and MPT, it's in 350-1.
Jeremy, thanks for that. Jeremy, thanks for the plug. So just for everybody's situational awareness, Colonel O, fantastic gentleman, came up with a great idea at the board meeting that we were at in the area, Jeremy. So again, thanks for the plug. We are planning to send out a letter to every attendee at the end of this year specifying the training that you received and that it may be considered eligible for a non-trauma module credit. But ultimately, to your point, sir, that will be up to your command. But we are trying to support that through this current line of effort. If we could do better, give us feedback.
One comment, so Sergeant McGarrett from SOCSENT. I went through last year with Lou, and I have to say, like, from 10, 15 years ago when I first started doing SOC Masseuse to this last couple of sessions, it has really increased in how they direct us and how they can give us feedback. So many props to you guys. My question to you is, what can the TSOCs do for you, or even some of the senior medics and the SEAs at some of these other units? What can we do for you to help you do your job?
I think the answer is really just to support more robust medical training at the unit level. Like Dan was saying, if anybody's lacking for ideas, we're happy to share. And it's not to say that we have we cracked any code or that we have all the answers or the best way to do it. We just have a way that seems to be working so far. And we think that what needs to happen is more repetition in the meantime between those required recertifications. We still get a lot of guys that come and say the last time that they did a medical training scenario was 2 years ago, the last time they were at SOC Masseuse. And I don't think that's suitable. I don't think that cuts it.
I'd say the most important thing for the TSOCs from the strategic level is to stop waiving requirements, because whether it's the medic or the surgeon who hasn't vendor required advanced trauma training, if you keep waiving the requirements and there's bad outcomes, we can blame no one other than ourselves. And that is the lever of action that's going to make commanders actually do the required training that they don't want to fund pre-deployment.
So I do appreciate that you enjoyed the course when you came through this past time. The success of the instruction is directly due to our instructors. Our instructors care. So they work really hard to come up with realistic, good, solid scenarios. They do a lot of research. It's not like there's any mastermind. It's our instructors that do the work. And so feedback from the force on what they'd like to see, but also if you conduct medical training and make it worthwhile for your medics, when they come to us, we can take them just a little bit farther. We can take them as opposed to they haven't done medicine in 2 weeks. You wouldn't do that with weapons training. You wouldn't do basic rifle marksmanship and then lock your guns away for 2 years and expect guys to be competent. So let's not do that with medicine.
Still got a couple minutes. Any other comments from the audience about other gaps that you're seeing? Or we'd really appreciate you to share any of your experiences on getting an uplift for your medical training. Any other experiences?
I'm surprised we got more questions. I thought we'd get beat up on this. Yeah.
All right. Hey, thanks, guys. Appreciate you listening. We'll be in the back. If you guys want to talk, we'll hang out this evening for as long as any of you guys want to have conversations. Again, you can reach out any way possible and let us help you guys. Appreciate it.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.